Hi, my name is Grace Lee, and I'm a clinical pharmacist here at CHOC Children's Neurology Clinic. Along with my colleague, Dr. Melody Sun, we are delighted to give you an introduction to anti-epileptic drug therapy. At CHOC, we have a team of pharmacists who are involved in medication management, and I want to acknowledge another one of my colleagues, Dr. Jessie Chang, for also contributing and reviewing the contents of this presentation. Some disclosures and disclaimers before we get started. We have no conflicts of interest to disclose. Given our practice experience, this information is largely pediatric focused, though many of the principles are applicable to adult patients as well. Furthermore, we are not experts on nutritional, dietary supplements, herbal products, or artisanal cannabis. We have several objectives for today's presentation. First is to provide an overview of how anti-epileptic drugs work, which I will from now on refer to as AEDs. While a discussion of all AEDs on the market is not feasible in the allotted time, we will talk about generational characteristics of each of the 3 generations of AEDs. We'll review the importance of medication adherence and tips on how to improve it, explain the role of drug level monitoring, and end with a discussion of common serious side effects associated with AEDs. By the end, we hope to provide you with a better understanding of the rationale behind how we use AEDs. This will enable you to have a better discussion with your provider on drug therapy matters. Before we can talk about AEDs, we need to start with an understanding of how a normal brain works and how seizures occur. An individual brain cell is called a neuron. We have over 86 billion of these in our brains. Each neuron is comprised of a receiving end called the dendrite and the transmitting end called the terminal. The axon connects the 2 ends and is capable of conducting electrical impulses. Neurons join end to end to form complex networks in the brain, which allows them to carry out cognitive and motor functions. Now, neurons come in primarily 2 varieties. Some send signals to slow things down, which are inhibitory, and others send signals to speed things up, which are excitatory. Think of them as brakes and accelerator pedals on your car. In order for a car to function properly, or the brain in this instance, both pedals need to function in coordination. When there is a discoordination between excitatory and inhibitory signals in the brain, repetitive, abnormal neuronal firing can occur in one or multiple areas and sometimes spread throughout the brain. This results in abnormal motor and sensory symptoms that are common signs of a seizure. Zooming in closer on how this exactly happens, let's answer what makes a neuron predominantly inhibitory or excitatory. Contained within the terminal ends of neurons are little sacs of chemicals called neurotransmitters. Neurotransmitters are released by one neuron and attached to neurons close by. Think of them as a way for neurons to communicate with each other. There are 2 main neurotransmitters we care about in epilepsy. The first one is GABA, which stands for GABA-aminobutyric acid, and it's an inhibitory neurotransmitter that slows down electric signaling. Glutamate, on the other hand, speeds up electrical signaling and is an excitatory neurotransmitter. Whether a neuron releases GABA or glutamate from its terminal determines what kind of signal it sends to the adjacent neuron. Again, seizures occur when you have a discoordination of these excitatory and inhibitory inputs in the brain. On balance, a patient with epilepsy has an overabundance of excitatory signals as a result of too much excitation with glutamate or too little inhibition with GABA. If I haven't lost you already, I hope this busy slide doesn't scare you off. Let's go through it. If seizures are an overabundance of excitatory signals, it stands to reason that the way to slow things down is either to dampen the excitatory signals or increase the inhibitory signals. Therefore, most of our AEDs either work by decreasing the effect of glutamate or increasing GABA by prolonging its effect. On the right is an excitatory neuron that releases glutamate from its terminal. AEDs that work on this system either block sodium channels, which slow down glutamate release, or blocks glutamate from attaching to glutamate receptors on neurons downstream. Both processes effectively decrease glutamate's effect. On the left-hand side, which shows an inhibitory neuron releasing GABA, AEDs work by allowing GABA to have a greater effect on chloride channels, or allows GABA to stick around longer. Either way, the effect of GABA is prolonged and electric signaling slows down. Of course, this is an oversimplification of what happens in the brain, and there are numerous other places where AEDs can work. Two things to take away from this is, when selecting AEDs, your provider may try to avoid drugs with overlapping targets to minimize additive side effects, or they may intentionally choose drugs with different sites of action so that you are attacking the seizure from multiple pathways. Secondly, some drugs work at many different places, while others narrowly target only one mechanism. AEDs that work at multiple target sites, such as Depakote, Felbamate, topiramate, and rufinamide, tend to work for multiple seizure types. When it comes to choosing medications, selecting the right one starts with having an accurate diagnosis for the seizure disorder you or your child has. This will determine which drugs should be tried first and steer us away from ones that should be avoided. All epileptologists strive for monotherapy, meaning the use of one drug only. Generally speaking, as long as the patient is showing partial response to a medication and not exhibiting any intolerable side effects, we will push the dose until we get complete seizure control or the patient develops bothersome side effects. A mantra we often follow is start low and go slow. So we'll often increase medicines in a stepwise fashion to get it to a target dose, giving the body ample time to adjust. For certain medications, we will draw drug levels from the blood to guide us in this effort. Using these principles, about 50% of patients will be successfully managed on the first drug they try. If the patient fails a first medication, a second medication will often be tried by itself using the same principles. An additional 10% of patients will gain seizure control with the second drug. However, if that doesn't work, combination therapy will be required. When selecting an additional medication, your prescriber will likely choose a drug that works at a different place or pathway. This will avoid the possibility of additive side effects. They might consider whether the new medication will interact with any of the existing medicines. Lastly, a medication may be chosen based on other pre-existing conditions a patient has, and whether the AED may improve or worsen the other condition. With all this talk about adding medicines, you may wonder if it's ever possible to come off of medications. This is highly variable and individualized, oftentimes having to do with the underlying diagnosis. But we typically like to see seizure freedom for at least 2 years, with confirmation with EEG, before considering coming off of medications completely. Until then, our ultimate goal for any drug regimen is achieving the best seizure control while minimizing side effects. If one cannot be achieved without sacrificing the other, then we will assess how quality of life is best optimized. For the next section, we will give an overview on AEDs, which are the mainstay of epilepsy treatment. Currently, there are at least 26 different AEDs on the market. A detailed discussion of each is beyond the scope of this presentation. However, you may hear your epileptologist refer to them by 3 different classifications. Based on chronology, AED can be categorized into 3 different generations determined by when they were approved. AEDs can also be categorized by their spectrum of activity into broad or narrow. This quality describes how many different types of seizure a drug is useful for. Lastly, when thinking about AEDs based on acuity, most AEDs are for chronic maintenance, while a handful of rescue medications are used to break prolonged seizures or frequent seizure clusters. The first generation AEDs were all approved before 1993. Some of the medications from this list, such as phenobarbital, valproic acid, and ethosuximide, are still used on a regular basis, while others, such as phenytoin and carbamazepine, have been replaced by newer and better versions. This generation of medications is notable for having many drug interactions, unpredictable drug levels, and therefore requiring frequent drug level monitoring and severe side effects. As a whole, the second generation AEDs have fewer drug interactions, more predictable drug levels. All were studied as add-on therapy, and some went on to get approval for monotherapy, meaning it has shown efficacy against certain seizure types when used by itself. Broad-spectrum AEDs can treat complex seizure types, while others are only effective against focal seizures. There are even extended-release formulation versions which allow for once-daily dosing to improve medication adherence. As many of these medications exist now in generic form, it bears noting that patients who are newly starting one of these AEDs should not be insistent on receiving only brand name product. Generic versions of these AEDs work just as well as brand and often don't require prior authorizations. The third generation of AEDs have a greater variety of pharmacological targets. Drugs such as perampanel, cannabidiol, and fenfluramine act on novel receptors. Others, such as ezlacarbazepine and brivaracetam, are touted as improvements upon their second-generation cousins. Some of them have very niche indications. Stiripentol and fenfluramine, for example, are currently only approved for Dravet syndrome. The mainstay of rescue therapy, which are treatments used to stop prolonged seizure episodes or seizure clusters, are a class of medications called benzodiazepines. They are extremely effective in amplifying GABA signals, whose inhibitory actions stop seizures in their tracks. They are controlled substances and tightly regulated by federal and state laws. Lorazepam, otherwise known as Ativan, is typically given intravenously in the hospital for severe seizures. Rectal diazepam, also known as Diastat, used to be the main rescue therapy in outpatient settings. However, the recent approval of two benzodiazepines administered through the nose, Valtoco and Nasolam, have vastly improved the ease of administration and afforded greater discreetness for a patient needing rescue therapy. With that, I'd like to turn it over to my colleague, Dr. Melody Sen, who will complete this presentation.
Thank you, Grace. Now that we have gone through the medications, let's spend a little bit more time talking about how to maximize adherence. Medications work best when you take them faithfully as instructed, but we know that life can get in the way of perfect compliance. Consistency is key. Try to create a routine that will help you remember to take your medicines around the same time every day. Associating it with an activity that is already hardwired into your daily routine, like brushing your teeth, can help. Make sure the medication is easily accessible during those times, like next to the dinner table or nightstand, or carry it in a keychain with you. Set alarms on your watch or phone as a reminder, and utilize medication compliance applications on any smartphone. Build a reliable team who can remind you to take your medication and hold you accountable. This can be a family member, friend, teacher, or school nurse. Lastly, don't forget to bring your medications with you on vacation. Your provider can write letters to help secure a vacation supply of medicine or provide justification to TSA. Just be sure to plan well ahead of time. Adherence is more likely when it is easy to do the right thing, so it is important to remove as many barriers as possible. Stay on top of refills as best you can. Ask for refills when getting health updates or during a clinic visit. Schedule auto refills if you're able to with your pharmacy. Some insurances may cover a 60 or 90-day supply, which decreases your chance of running out. Along the same vein, consider mail-order pharmacies that will deliver 90-day supplies to your doorstep. You can work with your pharmacy and insurance to set up these options. Also, routinely check that your medications are not expired. This is especially important for rescue medications, which may be used infrequently. Lastly, for medications requiring prior authorizations, try to stay on top of these dates as they typically take more time to process. If you have any medications taken multiple times a day, consider asking your provider to simplify your regimen. Inquire about extended release formulations when appropriate. At the same time, notify your prescriber immediately about any side effects that could be from your AEDs to see if they can be mitigated. You are more likely to be compliant if the drug does not cause cumbersome side effects. Be prepared for the occasional unpredictable and unplanned situation. If you or your child spits up or vomits within 30 minutes of taking an oral medication, it is safe to repeat the dose, since it takes roughly 30 minutes to an hour for most drugs to be absorbed from the stomach. The risk of having a breakthrough seizure due to low drug levels is often greater than overdosing on the antiepileptic. When in doubt, call your provider. For missed doses, we generally recommend taking the dose as soon as you remember and push back the next dose for a couple of hours. Document this on your seizure log. If you accidentally double dose, call the clinic or poison control. Observe for extreme side effects and go to the ED if necessary. Don't forget to bring your medications with you to any hospital admission in case there are certain medications that are difficult for the hospital to get. Next, I'd like to spend a little more time talking about why we ask patients to get blood draws and drug levels. When we take oral medications, the drug is absorbed through our stomach and gradually enters our bloodstream. The levels build up to a peak in the blood and gradually come down as the body starts to metabolize or eliminate the medication. It will continue to drop until the next dose is taken, at which point the drug levels will gradually start to rise again. This is demonstrated in the pink line on the graph here. The lowest point of the curve, right before the next dose is taken, is known as the trough level. For many, but not all AEDs, researchers have defined an optimal trough level range where a majority of patients will experience good seizure control without experiencing serious side effects. This is called the therapeutic range and is highlighted in orange on the graph. If the trough is below the low end of the therapeutic range, seizures may not be optimally controlled. If the trough is above the high end of the therapeutic range, there may be a higher risk for toxicity. The optimal trough level for any given person is highly individualized. That's why there is not just one goal level, but a range of levels that might be effective. Although drug levels are an essential tool for therapy management, they can be time-consuming to arrange and stressful to obtain. Here are some common reasons blood work may be necessary. When seizure control is good, we may want to confirm the therapeutic trough of a particular drug for a patient. That way, if variations in drug levels are ever detected, we have a target level associated with a history of good seizure control. When seizure control is poor, the level helps us determine how much room there is to increase a dose. If a side effect is detected, an inappropriately high trough level might be the culprit. When adherence is in question, we can use serial drug levels to track whether compliance is improving. When a drug is first started, we may check blood work to monitor signs of organ toxicity. As an important reminder, a drug level always needs to be interpreted in the context of what is happening clinically at that time. Any clinical decision we make should be to treat the individual and not just a number. Some tips on getting more accurate and therefore useful levels. Take medications and draw labs at consistent times as much as possible. The latter is not always feasible, but making an appointment with a lab can be helpful. If we are monitoring troughs, make sure levels are always taken around the same time of the day, before the next dose is given. Otherwise, trends will be difficult to detect. If getting to the lab on time is difficult, use an in-home phlebotomist. Try not to skip any doses, since any missed doses will lower the drug level that sometimes lasts several days after the missed dose, because it takes the body a while to reestablish steady blood levels. Related to this concept, if you do increase the dose of an AED, wait for at least 3 to 4 days after the dosing change to draw levels. We advise against checking routine drug levels when sick, since being febrile or throwing up may artificially lower drug levels. Many AED levels can take up to 5 business days to result out, so if getting labs prior to a clinic visit, please schedule them at least a week before. Lastly, request that your pharmacy dispense a consistent manufacturer for each AED. This does not mean you must stick with brand name drug only, but if you get generic, try to get the same generic brand as often as possible. Generic brands may vary up to 20% in drug composition and still be considered equivalent, and this can occasionally cause drug levels to fluctuate when you switch from one generic to another. Lastly, let's review severe side effects to watch out for. Because AEDs work in the brain, all have the potential to cause drowsiness and fatigue. In addition, here are a couple notable side effects that should warrant a call to your epileptologist. Liver injury can sometimes present as stomach pain, nausea and vomiting, yellowing of skin or eyes, and confusion. Signs of kidney problems are swelling in the lower extremities and decreased urination. Inflammation of the pancreas or pancreatitis can present as stomach pain and unexplained nausea and vomiting. Many AEDs can cause rashes, but severe rashes that blister, develop into hives, or involve the mouth and other mucosal membranes are very worrisome. Some AEDs may suppress the bone marrow, resulting in infection, anemia, or bleeding and bruising. Lastly, feelings of a fast heart rate, skipped beats, chest pain, and lightheadedness can be a sign of arrhythmias. Here are some last parting reminders. The best way you can help out your provider is to keep a seizure log that records when seizures occur, their appearance, how long they last, and whether rescue medication was required. Only with this information can your provider determine whether the therapy is working well and make better adjustments to your medications. We are partners on this journey, so please keep us abreast of any new medications that have been started, as they can interact with your current AEDs. If you have missed a significant number of doses, especially relating to insurance issues, please let us know so that we can troubleshoot or make contingency plans. If you have concerns for side effects, notify us immediately so we can address them. Please do not change medication doses or start or stop medications on your own, as the latter may lead to withdrawal seizures if not monitored closely. We hope this presentation has introduced and explained some new concepts that will help you work with your provider when discussing AEDs. Thank you for your time and attention.
All right. Thank you very much for your attention. Melody and I are both here today in the chat room. So if anybody has any follow-up questions regarding drug therapy, we'd be happy to answer just very generic questions about any side effects you might be seeing. But obviously, we can't comment on individual therapy as such. So does anybody have any questions or comments? All right, looks like we have a pretty shy group here, or a quiet group at least, but no worries. If anybody has any questions, feel free to just pop in at any time if something occurs to you. Melody and I will be here till at least 3 o'clock. So, so yeah, just let us know.